Hello everyone. Welcome to this presentation. I'm going to cover today the Combined Intelligence for Population Health Action Programme, otherwise known as CIPHA. And the purpose of today is to take you on a bit of a journey, something that we started back in about a year ago in COVID times, through to some very recent developments where the programme has been expanded. Exciting times for us in Cheshire Merseyside for sure, and very exciting, I think, for those partners who are due to join us. So let me take you back to where this started for us. Within Cheshire Merseyside at the start of the pandemic response, the response cells that were meeting discovered quite quickly that they had no regional platform for intelligence at that regional level. So we'd had some very rushed discussions with NHSX and managed to secure some funding for the GraphNet care-centric platform with some quite ambitious deadlines in place, given the nature of the pandemic. The most significant was, can you get all this delivered within, I think initially someone said 5 weeks, it then potentially was 3 months, but it became 5 months, which in any event is a mammoth task, but one which we achieved. So we you can see there that what it is we achieved in that time. So Cheshire Merseyside was some 2.5 million residents from all parts of, and we took our data from all parts of the care system. That's 15 acute trusts, about 350 GPs, 8 community, 3 mental health, 9 local authorities, plus emergency services. And we got all of that data combined together with all of the IG, which I'll talk a little bit about later. And we combined that with our national data sources, and we had our, including things like the DARS, we got a DARS submission in within about 12 to 14 weeks, something like that. So we had the SUS data as well. And then subsequent feeds later on, when we were able to secure Pillar 2 testing, the 30-minute feeds, and NIMS vaccination extract. So just a little bit about how that looked as an operating model at the time. It was a user-designed operating model based on the care-centric platform, where we were going to have regional dashboards, ostensibly around capacity and demand and epidemiology, and then to be able to provide intelligence directly into GPs and PCNs, together with a mechanism for looking at those additional use cases for researchers and for providers from acutes. So it was a fairly simple target operating model, and depended almost entirely on the development of use cases as the pandemic progressed and as these were delivered. The requirement was delivered to us through the response cells. So within the first 5 months, then, in terms of the kinds of things we delivered, we ended up with a daily sit rep. We had the testing information, hospital admissions, mortality, and so on and so forth, all through a BI platform. And then for those who wished their information to be delivered differently, we had snapshot data on a daily basis, and sometimes more than once a day, on email. And we quite quickly grew to about 1,000 users. And the thing that was, I suppose, for us most notable and pleasing was that we had a consistent way that the system across Cheshire Merseyside were viewing the data. And although it's a much overused term, this notion of a single version of the truth, I would say it was probably a single version of how we were looking at the outputs, and that was what was consistent, and that became a kind of a way of discussing the pandemic, was to reference the dashboards that were being produced, and they did develop over time, obviously. One of the we had a governance around it, as you might expect, in terms of the kinds of things we did, and a key part of what we did during that, in order to around that governance, was to put in information governance, set up that trust with our providers, and a key part of that was to be able to have this thing called the data asset and access group, and this was our kind of this was our assurance group, to make sure that those things that weren't, if you like, slam dunk within the DSA and originally specified in the data sharing agreement would go through a trusted group and a process, so our data controllers maintained the trust that they had in the in CIPHA, and we maintained the integrity of the data and the integrity of the data usage. So that was a key thing. As we progressed with the program, one of the things that became apparent was the need within the policy of the UK government through SAGE, was to be able to run a mass testing pilot and to see what the impact would be of mass testing on the population. And Liverpool was selected for this because of the access that we had to those data sources, specifically around populational health at a regional level. And the Department of Health, through their test and trace, were able to supply to us the 30-minute feeds. And then it meant that if you look at this as an example of the kind of output we were doing at the time, we were able to take each of the wards and understand who was being, the number of tests that were being completed, the lateral flow tests that were being completed, and what the what those results were, because we were getting them back in a timely way. And the really good thing about this is that it didn't just add to our understanding of testing, but it also meant operationally that we were able to get results back so quickly that we could see, when we looked at our other data in terms of incidents, that we could see where we could most effectively move one of the lateral flow test sites, which at the time, you may remember, being run through the army, pick it up in effect and put it into a ward where it could be the most effective, and then we could track that as it went through. And that was just simply because we had all of the data together in one place, and were able to support that as a piece of work. So that's where we got to with the CIPHA program, and so it continued, up until just some few weeks ago, when again further discussions with NHSX. When further discussions with NHSX, we discussed with them the expansion of the program, and working with GraphNet, we were able to construct a target operating model, which said that given the reach of the care-centric, the GraphNet product set, if you like, through very many areas, that we could set up a kind of federated view, or through a trusted research environment, of the CIPHA platforms. And so some areas don't have this yet, but our partners would come on board, and what we'd aim to try and achieve is that we'd have access for researchers who'd support sets of use cases and we'd have the teams themselves supporting their own use cases and then collaborating around what they may be, and in effect building up kind of blueprints for how systems can use data across regions. And we've had some fantastic response from a number of those partners coming in, and hopefully we will reach, say by September, we expect something like a 16.7 million population where we can share the developed either in-flight use cases or new use cases using the GraphNet platform across those areas. And we will also, and one big part of this, you'll see at the bottom of the target operating model, is to contribute towards national research and national policy. And we're already having some of those discussions with, for example, Public Health England. So just give you a flavour of the kinds of things then that would enable us to do. So for example, from within Cheshire Merseyside, once everyone's got the same access to the same data sets, we'd be able to link COVID vaccination by having a NIMS extract to testing, and for that testing data to come in every on that 30-minute feed. And this is really important. And again, just talking nationally, it's the kind of thing that people want to be able to see at that level of detail for planning and operational purposes. And then to link that to link it also to both admissions and to testing, so we can know in an almost real-time way how the vaccinations impact on our on the admissions of COVID post-vaccination. And then the work that we're talking to Public Health England about is, well, what about side effects? What about the blood clots? Can we now see examples of where that might appear within that, or where other side effects, such as they arise, might happen? And we're also talking about, well, what happens to those to pregnant women if they've had a vaccine, and what are there any other subsequent side effects? So we've got a real opportunity to examine some of those, both from a research and operational perspective. The other thing that has been developed within Cheshire Merseyside is the 4 tests to recovery, like an early warning system, where we can look at vaccination, hospitalisation, incidence mortality, and variants of concern. So we're at a position, and there are deeper drill throughs onto each of these sections, but to really understand what are those things that will alert the system if we need to make interventions later on as we move into, say, local interventions or surge testing or such like. From other areas such as Frimley, who are partners in this, one of the things they're looking at is and have developed the dashboards and reporting is to address the government challenge around health inequalities and waiting lists. So if you add as they have done, add a PTL flow, then you're able to identify those on waiting lists and then stratify them in terms of their condition, and then decide on what intervention may be appropriate whilst they're on the waiting list, or even, and this may be a possibility at some time in the future, even altering the waiting list based upon the intelligence that you have developed. The other thing that's being developed, again, both within Frimley and also in Greater Manchester, is to look at pulse oximetry. And I use all these terms, they're not synonymous, but the idea is, in a sense, a general idea around things like pulse oximetry, virtual wards, telehealth, which is where you're able to identify a population based on the thresholds of condition, the entry conditions that you set for yourself. You're able to manage through that condition, or in this example, manage those on a virtual ward to understand how long they'd stay on and so forth. And you can pick up through each of these. You could click on an individual, and by the way, these aren't real names or real people in this example. But you could click on one of the names and you would be able to identify how the conditions that individual, see, if you like, the full record for that individual, and then also understand when they might be discharged. So this also applies to things clearly like blood pressure at home, but it's all of those kinds of services that require this kind of cohorting, identifying, stratifying, and intervention type activity. So where does this what does this take us to in terms of the CIPHA expansion? Well, we're setting up the program right now. We're looking at how we deliver the trustworthy data and analytics environment for researchers and others, how we'd federate the data. We're putting in place the plan, we're putting in place the governance and the forms we might require for data access. We got fantastic support from NHSX in terms of some of the work that they're doing with us, and huge enthusiasm from those partners that we've introduced so far into the program. So I'll leave it there for you on that note of the journey continues, because I think this will only expand, the number of use cases will expand, and we will make these shareable so that everyone can take advantage of the use of data and analytics to support population health during COVID and post-COVID and into system recovery. Thanks very much for listening. I'll take questions in the panel. Bye-bye.